Hey, it's Dr. VandeBerg. I am excited to share this conversation I had with Dr. Naurine Shah. She is an orthodontist who's going to start working here in our practice in Prosper, treating patients with myofunctional problems, which is a fancy way of saying patients who have issues with airway, breathing, sleep, speech, and swallowing. And I don't know that there's a lot of people here in Prosper that are treating these patients, or even in Dallas for the most part. Orthodontists don't get any training on this in school. So she has taken, I think, a dozen different courses on this and is changing people's lives. So I'm excited for you guys to hear what we have to talk about, and thrilled she's going to be working here in our practice in Prosper to serve this community. Dr. Shah, thanks for joining me on a call today. I'm excited that you're going to be joining our practice and treating patients with myofunctional issues. So I'm excited to talk about this because I kind of feel like I'm a mouth breather. And so let's talk about that a little bit.
Okay. So thank you for having me, Dr. James. I think it's important that we figure out if you're a mouth breather or not. So show me how you watch TV or sit in front of the computer or when you're driving. What is your posture like? Is your mouth open?
So let's see. So like if I'm at a computer,
yeah,
I guess, yeah, typically I'm like, or if I'm driving.
Do you ever play video games and your mouth is open?
I don't play many video games, but TV, driving, computer, that's when I'm kind of like zoned out and I'm just kind of doing my thing. But yeah, I do kind of find myself
with your mouth open, right?
Yeah.
So do you find that your tongue hangs out on the bottom of your mouth when that happens? Because you gotta breathe with your tongue down if you're a mouth breather, right?
I guess so. I don't know. I guess I don't know where else my tongue would be.
Right.
Other than sitting, yeah, it sits down, yeah.
Right. So when your tongue's down, you can't breathe through your nose. Do you want to try that for me? Try breathing through your nose when your mouth is open. It's hard, isn't it?
Yeah, it's weird. It doesn't feel natural.
You're going to have to think about it. And breathing is such a natural process that you can't really think about it all the time. So anytime your mouth is open, like with us when we put our makeup on, when you're watching TV, sitting in front of the computer, lifting something heavy, when your lips are apart, your brain's going to think that you're either going to talk or breathe or, you're going to do something with your mouth open, like bite your nails or put something in your mouth.
Yeah.
That's why you'll choose to breathe through the mouth. But a lot of other things come with mouth breathing. Do you think you snore at night?
My wife definitely says I snore at night. Yep.
Okay. Is it loud snoring? Do you move around a lot in your bed?
I know I move. I have a hard time sleeping. I never sleep well.
Oh, yeah.
So my wife says I snore, and I know that I'm tossing and turning all night. Yeah.
Right. So the quality of your sleep when you're breathing through your mouth isn't great. When we had babies, which both you and I have, we were told to make sure that their nose was patent, so they were able to breathe through their nose. So nature always wanted us to be nose breathers. But if you breathe through your mouth, you won't get the quality of sleep, the REM, the rapid eye movement, the deepest part of sleep. You will never get into that because you're breathing through your mouth and the quality of the oxygen that your brain filters is not as great as when you breathe through your nose. So your tongue isn't...
So I have a question. So one of my nostrils, I can't breathe through.
Right.
I can't get air through there.
Right. So you might have what's called an enlarged turbinate. You might have had some allergies in the past. You might have had trauma to your nose. So the turbinates enlarge and cause physical impediments. So you actually can't physically breathe through your nose. So of course you have to breathe. Your brain's going to choose the mouth to breathe. But when you do breathe through your mouth, your tongue's in the way. So you're trying to get the air over your tongue into your lungs, but the tongue's in the way and it flaps against the uvula and creates the turbulence that you hear as snoring.
Yeah. Is this why when I was a kid I needed an expander? Do you think?
Yes. So if you think about it, your top jaw, which is the maxilla, stops growing at age 7. And if you didn't have your tongue up there because of the fact that you couldn't breathe through your nose, because we just figured that we can't breathe through the nose if the mouth is open, it won't develop around the tongue. And that's why your teeth all got crooked, because the tongue never provided the natural expansion. You also have to chew and swallow with your tongue to the roof of your mouth. You want to show me how you swallow?
So I got some handy dandy snacks.
Yes, let's have a
to
look.
practice with. So what do you want me to do?
Yes, let's try the cracker first. Let's see how you swallow. Take a normal bite like you would.
Okay, this is very self-conscious eating and being evaluated. Okay.
It's okay, Dr. James. I'm not gonna, oh yeah, okay. So you are a fast eater. You took a bite and then you're chewing. But you're only chewing on your left side.
Yeah.
Yeah. And then, okay, so I saw you move the food around, and then you used your head to bring your head forward to push the food down. So that's actually called the forward head posture while swallowing. So what you want to be able to do is chew both sides, collect the food on top of your tongue, put your tongue in the roof of the mouth, make sure the tip doesn't move from the roof, and then use just the back to swallow.
Okay.
Another bite and show me.
Okay. Do it again.
Yes.
And try to do it the right way.
Yes. You're going to try to chew both sides. So your tongue is kind of like the floater. It's going to take your food from one side to the other. And then you're going to collect the food on top of your tongue.
Okay.
And I need your lips together when you're chewing, please.
No problem.
We don't want any noisy, messy chewers at our table. Okay. Excellent. And then use your tongue to collect the food. Okay, put your tongue up, teeth together, and swallow. You still brought your head.
I did.
Yes.
I did that.
Why do you think you do that?
I have no idea. I'm just eating. I just eat.
Okay, let me explain that to you.
Yeah.
So because the tongue doesn't have the tone and the strength to actually create peristalsis, which is the first part of gut movement of food down your throat, you're going to use extrafacial, extraoral muscles to push the food down. So we're going to have to work on your tongue, Dr. James.
Oh, great. I'm going to become a patient.
Excellent. Let's try the apples. Let's see if you do better with those.
Okay, let's see.
Okay. Now that you know how to chew, okay, so watch how you use your neck. So try not to involve a lot of your neck muscles. So relax and use your oral muscles to chew. Excellent, you got this. And then you're having trouble keeping your lips together, aren't you? A little bit, okay. All right, so.
I'm not very good at eating, apparently.
You're not a good eater, huh? So let's think about the texture of the apple. So it has like a covering, and then there's a soft part, and then there's some juice that comes with it, right? The next step I want you to do is when you take your bite, you're going to try to focus on lifting the juice up in the back of your tongue as you chew. So you're trying to swallow the juice with the tongue up as you're chewing. So you're collecting the food, but also picking up the watery part of it.
Okay, go again.
Yes, please. Good. Okay. And you're not using as much of your neck, so that's fantastic. Good job, Dr. James.
Using my brain.
Okay, and let me watch you swallow that without moving your head forward. Excellent, you got this. Fantastic! Did you feel the difference?
Yeah, it was easier to swallow. Yes, for sure.
Yes, absolutely. Let's see how you drink now. Do you have a straw on you?
I do. I've got a beautiful purple straw.
Excellent. Let's see where you put it. Where do you put it to drink? Okay. Where is your tongue? Is it on top of the tongue or?
It's on top of the tongue.
Okay, so take your sip. Okay, so did you see what you did with your tongue? You push the straw out, and then you push the water down.
Yes.
right? Okay,
Yes.
let's do it the right way. So you're gonna put your tongue to the end spot.
I thought I did so good.
Huh?
I thought I did so good.
Well, I'm not judging you, Dr. James. We're
Okay.
just teaching our patients.
No, this is good. Yeah, let me know what the right way is.
Let's do it the right way. You're going to put your tongue out to the roof of your mouth. You're
Okay.
going to send your lips out, feet together. Yes. Take a sip, and without moving your tongue, you're going to swallow. You can take the straw out, though, if you like.
Okay, I didn't move my tongue.
Sorry?
I didn't move my tongue.
Excellent. But was that different?
I don't know.
Okay.
It's hard to tell.
It is hard to tell. Let's take the straw out and drink from the cup.
Okay.
Okay, can you turn your head around so I can see? Okay.
Like this?
So you have a tendency to lick your lips after you collect the fluid, right? You want to make sure that it's not dropping out.
Okay.
Okay? This time you're going to try to keep the lips on the cup, pour the water, and then see if you can lift the water with your tongue to swallow just using the back of your tongue. Excellent. How's that different?
I felt like I was going to choke on it.
No way!
Yeah, I almost went down the wrong pipe.
Really? Okay, so your tongue is so used to pushing and shoving the food and the water down your throat that when you're trying to do it the right way, you're feeling like you don't have the strength and, just the regular process about it. But we can learn about that.
So how do you teach someone how to eat and drink and swallow the right way? What do you go through?
So the biggest part of it is to know what dysfunction is from function. So like you were not aware that you were doing any of this, right? So
I thought I was going to pass with flying colors, and I failed.
There's no such thing as failing. You just made a mistake.
Okay,
I'm glad
good.
that you're admitting your mistake. I'm kidding. These aren't mistakes. These are normal neuromuscular patterns that we're born with, and we just developmentally, we just, accustom ourselves to how we eat and drink. But I have to tell you that it is very, very important for us to look at function and not just straight teeth. Both you and I are orthodontists. We were never taught function in school. We went to school for 14 years after high school, but no one talked about how to eat, how to drink, how to swallow, how to sleep, how to breathe. Those are all functions of the orificial complex. We were just never taught that. And if you think about it, we are tooth specialists. We should be the ones knowing what the best way to function is, right?
For sure, yeah. Has a huge impact on where the teeth are. So what's the difference between, what treatments, what conditions does a myofunctional orthodontist treat that a traditional orthodontist doesn't treat?
So, because we have to look at relapse very carefully, it's one of the reasons why patients have to go through orthodontics multiple times. I think if we train our muscles, like our lips and our cheek and our tongue, to retain the results of orthodontics, then patients wouldn't have to go through this. At the same time, it improves their quality of life. So the other things that we look at is thumb sucking, because if you think about it, your tongue stays down, your mouth stays open, you become a mouth breather, your palate grows around the thumb or the fingers instead of the tongue, and then the palate collapses and you get crowding and all that stuff. Then we have to go in and fix the crowding, but if we didn't treat the reason, we would still face relapse. Mm-hmm. So thumb sucking is one, texture sensitivities, tongue tie issues, tongue thrust, sleeping with the mouth open, clenching and grinding, snoring, all of those things are connected. There's been tons of research on how the quality of sleep also affects attention deficit, and so ADHD, bedwetting, several of those disorders are now becoming related to level of oxygen when you're sleeping. So nasal breathing is our goal, and we've got to make sure that patients can breathe through the nose when they're eating, drinking, sleeping, breathing, even exercising.
Okay. So do you put all your patients through their snacks and their waters?
Yes. So, if you were to come into my practice, I would watch you eat and drink, possibly record it for you so that at the end of treatment, we can look at those videos and see what changed.
Okay.
And most of the times, and I also have to ask, and maybe I'll go through this with you, I'm pretty sure you're not tongue-tied, but I haven't had a chance to look at you. But if you, it's kind of hard to tell over right now, but I
know.
to give out the check.
You're right.
But if you're tongue-tied, then you would have issues with speech. Now, you would have gone through a ton of speech therapy and not been able to fix some of the consonants of S, SH, CH, because that is a physical disorder stemming from tongue-tie. So it's important for us to look at all those functions because, like I said, we are specialists. We should be looking at that stuff.
For sure. So I'm curious, you went to a residency for orthodontics.
Yes.
How did you get all this training outside of your residency? What did you have to do to become kind of like a myofunctional specialist?
So none of this came from my residency, Dr. James. No one taught us anything. Maybe we looked at tongue thrusts a little bit, and I'm sure you agree.
I got zero. I got no training.
Yeah, no training. No training on sleep, no training on any other function. Just the fact that you can put your teeth together. If the cusp falls in the fossa, you're okay. But that's not where function stops. We are living, human, breathing individuals, and we chew our food, eat, drink, sleep, do all those functions. But my education came when I was a general dentist for 12 years. I saw that there were patients that went to ortho, then went to ortho, and it didn't make sense to me as to why I've never had braces. I've been a chronic nose breather all my life. My teeth have
never had braces. Never had braces.
Never had braces.
Look at you.
So then I started looking at some growth patterns of why certain people have crooked teeth, because it's a question of curiosity. Like, why do I have straight teeth and why do you not have straight teeth? I found habits and the fact that you probably don't rest your tongue properly or breathe properly or eat properly and then rest your tongue in incorrect positions, breathe through your mouth, which causes crooked teeth to happen. But as I went through my training, I realized that the biggest thing to measure all of this was sleep. And so I worked with the sleep clinic and taught them how to strengthen the oropharynx muscles to help with breathing at night, because most of them could not tolerate CPAPs. A lot of patients hate CPAP because it's such an annoyance and it's just a Band-Aid. Yeah. But there's been tons of research on how myofunctional therapy actually improves the AHI, which is the apneic-hypoapneic index, which should be really low for you to get a good quality sleep. It physically improves that index about 80 to 85%, which is a massive change. All right, so
new patient comes in to see you at the ortho office. What should they expect, and what are they going to go through?
Okay, so I'm really excited to be able to provide this service at our Prosper office. Not only will we look at your orthodontic concerns, but we'll also evaluate you for your function. We'll make you eat and drink and document and have a chat with you about the airway concerns, and then offer you a complete comprehensive program customized to all your concerns, which will include addressing thumb sucking, nail biting, mouth breathing, chewing with the mouth open, texture sensitivity, speech disorders, and that will be a part of your treatment as far as your orthodontic treatment is concerned. We might use different appliances, we'll go through a program of exercises, we might use some laser. There might be the need of a laser frenectomy for the tongue tie release if there's one. There might be some palatal reduction for adults, for those that have sleep apnea. We might be using certain appliances to expand the palate for patients that have CPAPs and stuff so that they can help get rid of them. Or there might be some surgical options that we might be able to offer to you.
Okay, so I know a lot of this has to do with sleep. There are sleep studies out there. Is that something that we're going to incorporate in the practice?
Yes. So if we find that sleep is an issue for you, we'll do a questionnaire, goes through some of your symptoms and what your history is like, and then give you like a sleep test to take home so that you can record your oxygen saturation levels, and then we can suggest the treatment modalities based on that.
So they don't have to go to a sleep center and go sleep in some clinic somewhere?
No, they don't. They'll
Okay.
say, we'll do that complimentary for you, and then we'll go over the results with you and show you what your options are for treating your sleep disorder, breathing, or sleep apnea.
Okay. So somebody who's going through orthodontic treatment can also be treated for these myofunctional things kind of independently.
Absolutely. So there is a program that we'll exclusively offer to the current orthodontic patients in your practice, Dr. James, and we will identify those disorders and have a customized plan for them. It'll be 10 sessions over about 3 to 4 months that the patients will come and see us for, and then we'll go over certain protocols to teach them how to chew, eat, drink, bite, and sleep. As far as breathing is concerned, we'll have breathing exercises for them, and we're hoping that your orthodontic results will be much better and that you'll be able to retain the result support though for a very, very long time based on your function.
So if someone is watching this and they're thinking, how do I know if myself or my husband or my kids have these issues? What should they be looking for so that they know that they need to come see you?
So you just need to watch each other just to make sure that, when you're sitting in front of the computer watching TV, are you breathing through your mouth? Are you using the straw correctly? Are you not bringing your head forward to swallow? You're not chewing with your lips apart, smacking your lips. And then also a big thing that we don't tend to notice is the reverse swallow, which is like that.
Oh, yeah.
I saw you do that, Dr. James, and I know Dr. Graves does that too. So
Okay.
that's when you leave your tongue down, use the back of the tongue to push and use your jaw and your neck muscles to swallow. Those are really easy things to identify. But if your child or you are nail biting, if you are grinding at night, if you're not sleeping well, if you're moving around a lot in your bed, if you have speech disorders that have been identified but never been treated because of even going through speech therapy have not been fixed. So those are the things that we can absolutely help you treat.
Mm-hmm.
And I can assure you that there are very few people that are qualified to do that. And it's very important that you find qualified people and help you get to your goals that way.
So I see kids like 7 or 8, they come into the practice and all of their baby teeth on the sides are flat, like bricks, like down to the pulp chamber.
Right.
Is this potentially a breathing, sleep problem?
Absolutely. So up until recently, grinding and clenching was not considered a sleep issue, but now there's been tons of research that grinding is actually a response of your airway. So imagine if you're trying to sleep and breathe at the same time at night, but your tongue's occluding your airway, your natural response would be to bring the lower jaw forward so you can at least breathe better. It's like a panic thing for your brain to be like, hey, you're being held underwater, you can't breathe, so bring your jaw forward kind of thing. Okay. When that happens, obviously the wear causes the grinding. And I potentially think that is a huge airway disorder, and those children should be seen immediately for expansion and better airway protocols.
Okay, good to know. I'll send those kids over.
Thank you.
So is there anything else that you would like, the world to know about this myofunctional orthodontics and airway and breathing and eating and drinking that we haven't covered today?
So I think it's important that we bring to light all those who are not aware of this. So there will be those that will be like, okay, where's the research? What do you think works? How do you know all this? And I want to say that it's not anecdotal. It changes people's lives. We just don't have the information or the qualified professionals to give us that information. And so somehow, if you start going through this rabbit hole, once you realize that the tongue plays an immense role in your growth, in your development, how your jaws grow, how that affects breathing, which inadvertently affects your function, how that affects your speech, how that affects your sleep, I think it's a big question mark on those people who are not looking at these and don't think there's a problem. We can't just shut our eyes to this, Yeah. It's an emerging field. The airway is important for good life quality. And if we as specialists who've been to school for years about this can't address it, then I'm not sure how we can help our patients on this.
So this, as orthodontists, we know this is a controversial topic in orthodontics because we hear people out there saying some things that go against some things that we learned in residency. And so, unfortunately, I think myofunctional orthodontics gets automatically lumped into some sort of kooky magic treatment that that maybe people don't need, or is just weird. So, can you shed some light or speak to that a little bit? That there are some people out there who are talking about this in a way that just doesn't make sense to orthodontists?
Absolutely. So, like we talked about earlier, we didn't learn about this in school. And somehow, because we didn't have that background, we didn't think it was important. But you also have to be cognitive of the fact that people are taking this to a level without doing their research on what actually works. So, there's people that are expanding at the age of 3, using certain appliances when obviously the airway is developing. But I think education is the biggest aspect of knowing what's right for you. And then trying it with your patients to get the right results. And for me, I've been doing this for over 12 to 14 years. Like, I've seen how it helps children with their breathing, speech, all of that stuff. Parents are super grateful when it helps them. We just don't have any association or a society to teach dentists or orthodontists about this. So those who go through this rabbit hole, which, mind you, a lot of people are now paying more attention to this. There's lots of interest in this because we've seen the effects of it, relapse. The fact that snoring and sleep apnea has become so common, but no one is actually physically treating it as a problem of function. So I think that the concepts are changing. We're getting more information about this out there. There's Dr. Zaghi, he's our mentor. He's the one doing a ton of research at Stanford about this. He's a huge advocate of myofunctional therapy, and he has a ton of orthos and general dentists and surgeons that work with him. So I think we're changing the landscape a little bit. And it's important for us to keep our eyes open. We just can't, just because school didn't teach us doesn't mean we're not going to learn something.
Yeah. I hear a lot from parents that when I talk about extracting teeth, they have done some research on the internet and heard some things, even from their general dentist, that if we extract teeth, we are going to be restricting the tongue and blocking their airway and causing some very significant airway issues down the road for their child. Is there any truth to that?
So traditional research tells us, and obviously I have to speak to that, is that there's no difference between the airway as far as extractions and non-extractions. But if you think about it, why would you not have enough space in your mouth for all your teeth? The crowding, the cause, going back to that, like, why didn't we have enough space? So even if we did extract teeth and didn't treat the cause of why it happened in the first place, I don't think it's fair for our patients to just assume that everything's going to be okay. It's like saying we're going to do surgical orthodontics, orthodontics. We're going to move the whole house, but we're not going to move the furniture, So whether you extract or not, I think it's based on all orthos' personal judgment of how they want to make sure that the results are in biological widths and stuff as far as teeth positioning is concerned. But at the same time, I don't think there's, if it's necessary, we should extract. And at the same time, we should treat the cause and not just the symptoms.
Yeah.
Because there's so many Band-Aids out there, right?
Yeah, so what I'm hearing you say is that it's a case-by-case basis.
Absolutely. It is a case-by-case thing.
And making that blanket statement that if someone extracts teeth in a patient, they are causing a problem for this patient later in life with their airway. And that's maybe misguided or maybe just too generalized of a philosophy to apply to every single patient. So.
Well, if you think about it, James, what was our way of measuring extraction and non-extraction cases, right? We were looking at CBCTs, but we've never had a protocol on the natural head position for the CBCT. So you could change the natural head position and look at the airway in so many different spots. So we've got to have parameters for those researchers doing that to make sure that all our variables are matched. So if you take a CBCT with the head up and then you take a CBCT with the head down, you're not doing any favor to the airway, and that doesn't make any difference whether you extracted or not extracted teeth.
Right.
So some of that research doesn't have the parameters that we really need to be looking at.
Got it. Fascinating. Well, I'm excited to have you in the practice. I'm excited to work with you and learn from you. And
Absolutely.
I think for our community up there in Prosper, I don't think there's anyone else providing a service like this. But I think there's a lot of interest, and I think you're going to help a lot of people. So I'm excited that you're going to be working with us.
I am super excited. I think it's going to be a huge benefit to our community. And once we start talking more about this, I promise you, it's going to be very common for patients to go into an ortho practice and ask if their function is going to be evaluated. Mm-hmm. That is a huge service because not a lot of people are doing that out there.
No, hardly anybody. So, well, great. Well, thank you for taking some time with me today. And
thank you, Dr. James. I'm excited.
Yeah, well, we will talk soon, and have a great weekend.
Fantastic. You too. Thank you.
Thanks.